All right, we are back with another episode of Claims Denied. Today, I am joined by a special guest, Dr. Ali Khan. He is what are you again? You're the chief something of Medicare, of Aetna, of...
Yeah. Chief Medical Officer for Aetna Medicare. So our Medicare and duals book around the country.
Okay. Yeah, there you go. And that's awesome. And so super excited I think we're going to have a wide ranging conversation today. I'd love to, talk about your background first and then get into, value-based care and kind of the evolving role of managed care and the BUCAs and consumerism and all of the above. So thanks so much for joining me today.
All right, let's go. Thanks for having me.
All right, let's do it. How about you just give me your background first? I mean, you've been in a lot of unique roles in healthcare. Would love to hear it from the horse's mouth.
Yeah, I'll try to be brief on this. I tend to get wordy, so we'll keep it short. So I'm a practicing primary care doc, a general internist. I still practice here on the west side and south side of Chicago at Oak Street Health, where I spent a number of years in a variety of roles. The last 3 as chief medical officer, which just a profound privilege. But my career really started, about 15 years ago, where I took a lark and spent 3 months of my last year residency in Vegas, in a fun way, but not that kind of fun. But taking care of super sick casino workers on the Strip in Las Vegas, working under Andrew Schutzbank and Rashika Fernandez-Poulet at the first Iora Health clinic that served, the Iora Health, the casino workers union in Vegas, in a community health worker centered, high touch, high intensity, ambulatory ICU, fully VBC practice. That was just the highest functioning healthcare team I'd ever seen in my life. And so I think that exposure, after having practiced obviously for a number of years and training in both traditional fee-for-service settings and then in the VA, which I think in primary care, probably one of the most functional things you can see in the country, outside of, obviously some of our value-based care work, in terms of just being a system that connects the dots for people to try to get them the help that they need, the services that they need, the DME they need, all that stuff, and does it in a reasonably timely manner. We don't talk about that enough, right? But so I think training in that kind of environment led me to know, like, hey, primary care can be something really interesting, something fulfilling, something meaningful. And primary care can be practiced in a way where it doesn't have to suck, right? So I got really lucky in terms of, landing early with Iora, and as employee 34, being able to do all sorts of things across Iora's initial foray into Medicare Advantage with Humana and helping to open clinics in Arizona and Seattle. Then, Iora and United's big effort on the exchanges where we built an ACA product with Iora Primary Care at the center in and around Chicago and Atlanta, built a physician recruiting function and nursing recruiting function from scratch, did a bunch of other things, coded in Git for like a better part of a year as a doc embedded in the technology and product team, and just got this a sense of what is it like to build something entirely de novo, and was having a blast. But, 2 kids in, while commuting from San Francisco to Vegas, because my wife was in San Francisco, I was like, hey,
gosh.
Maybe I shouldn't fly to Vegas every week with a wife and fellowship. And I was like,
poor woman.
Yeah. A lot of people say that. What's exciting going on in Northern California? And I remembered, hey, my grad school TA just took some job for some California-based health system, a health plan. Maybe I should see if they have Northern California operation. So that grad school TA happened to be Sachin Jain. And so lo and behold, a few months later, I was lucky enough to be leading the Northern California market on the clinical side with co-P&L ownership for CareMore, CareMore Health Plan and CareMore Health System. And just a place where I got to see what it's like from that original era of managed care, right? Like the healthcare partners era, the CareMore era, the early days of ChenMed, where the focus of everything was really on total cost of care, right? And how can you use really proactive clinical care plus all the plan features of utilization management and care management and claims and network and stuff like that? Can you actually make that a virtuous cycle? And so at CareMore, I was not only the health plan medical director and the health plan CM medical director, but I was also the hospitalist, right? For when CareMore members got admitted to Regional Medical Center of San Jose or to Good Samaritan Hospital in Santa Clara. And so when they'd show up and I'd be like, hey, in the ER, I'd go see them just to evaluate whether they could be admitted. But in the time from when I got a call to like the 18 minutes by when I'm walking into that ER to go see a patient, right? I would have already like spoken to our care management team, gotten a full sense of what the picture was of this patient, obviously looked at the ER records to see, hey, they're coming in, let's say for like a mild asthma or a COPD exacerbation. But we know they've been falling a bunch at home recently, and like we see them a bunch in clinic for a bunch of other things. And what they probably could benefit from is going to actually directly to SNF, right? Going to skilled rehab,
Mhm.
getting the same medical care there for that asthma exacerbation that they could get in the hospital or at home, but then get access to that, multiple hours a day of physical therapy or speech therapy. And the way we designed our insurance product at a $0 copay for all those days that they're in skilled nursing, with my team seeing them and me 4 to 5 times a week, right? And like I would be walking into the ER in that 18, 19-minute period with an authorization already for that SNF bed, with an authorization already for the ambulance to take them to SNF, and with 3 SNF beds that I'd already arranged by contacting folks that we've worked with frequently, right? In terms of sculpting the network. And my only job was to go in, see the patient, and make sure I didn't anchor in the wrong way. That, oh, this person actually is really sick and needs to stay at the hospital, right? And if they didn't want to go to SNF, but they weren't in need of a hospital, I could also get them a clinic appointment the next day, right? With our CareMore team outside of their primary care doc and do all this stuff, right? Get the DME ordered, get the nebulizer to their house same day, that sort of stuff. And I expound on this. I told you I get wordy, but only because it's like I saw this moment. I think that I've been chasing the rest of my career of like, hey, when it works well, a health plan and a clinical layer can come together and orchestrate a lot of really good things, right? And the question is, can you
Yeah.
actually do that replicably at scale outside of places like California or Florida, right? Like, how do we do this
Yeah.
consistently?
Yeah.
And so, CareMore was this grand adventure, but fast forward a few years later, life had brought us to Chicago for a variety of reasons. And I'm looking around Chicago being like, hey, it's early 2019. I'm like, hey, I'm on Zoom a lot. Famous last words. I like, and like, there's no CareMore in Chicago. I want to be doing the leadership work that I'm doing where I'm practicing clinically, because I was practicing clinically here at a federally qualified health center and then at a university medical center. And I was like, where can I put it all together? And it turned out like this shop you may have heard of called Oak Street Health, happened to be 6 blocks from our apartment. Right. So like in
Never heard
early
of it.
20,
Never heard of
yeah,
it.
early 2019 took a leap, coming in as executive medical director for the largest division at the time. My diet partner and I took that division from 1 state and 23 clinics to 8 states and 75 clinics over the course of 2 years, including through the pandemic, right? Opening tons of clinics and doing a bunch of stuff. And then, just had the incredible privilege of working under people like Mike Picos and Jeff Price and Griffin Myers, Dave Buchanan, and others. But really, being able to see this incredible, I think of Iora as a great place from a cultural rigor perspective. I think of CareMore as a place, incredible clinical rigor, especially putting like, all the pieces of plan operations and clinical stuff together. And Oak Street's like, we're a Midwest engineering story, right? Like operational and growth rigor and just seeing how we get the trains to run on time to make sure things happen for patients over and over again. That was just an incredible privilege, which, so then it's when CVS bought us in 2023. I was like, hey, maybe to make the deal terms work, which, yeah, I feel like, is always a question when in these kinds of acquisitions, maybe jumping to the other side of Aetna means that there's people on both sides who want to get this synergy to really to work. And so made that jump in 2024 and have been really privileged, A, to make sure that we're getting the deal terms to work, but B, also to be able to, see the whole field and understand what's happening across the whole landscape of both value-based care and traditional fee-for-service care at a time for Medicare Advantage where, there's a lot of really important questions on MA, right? I think the fundamental question becomes Medicare Advantage was theorized, right, from a statutory perspective to lower costs and improve quality and connect the dots better for people. And at this moment, especially after V28 and everything else, I think it becomes a question of, can Medicare Advantage do the work to drive last mile clinical stabilization for people, right? Are we actually doing the work to get people healthy, to keep them at home, to keep them out of the hospital? And how are we doing that with more than just what's required of us from an NCQA perspective or from a compliance perspective, but that we're doing that consistently on every single person? That I think is the challenge and the fun of this job.
Yeah. And Wow. So thank you so much for that background. I mean, incredibly cool work. And starting from Vegas, ending up at CBS. I mean, maybe that's like a closed loop there. I don't know. No, I'm just kidding. But
I guess oftentimes things in Vegas bring you to a pharmacy, but that's a different story altogether.
oh yeah, that's true. That's true. Maybe like a peptide pill mill at this
Yeah,
point or
exactly.
something. Who knows? Um, yeah. Okay. So um, lots to unpack here. I think the first thing I want to ask you is. Um, in being at so many different places and both being on kind of the provider side, being a physician yourself, and now being on the insurance side, how have you seen kind of healthcare evolve? And how would you kind of assess like the current state of value-based care, payer provider collaboration, those sorts of things?
Yeah, Blake, I mean, such a good question. I think that I would say the evolution has been less around sort of like the theory of value-based care, but more about like where have we seen execution, right? So I think like again, you go back to that original era in the 90s and early 2000s through the early 20 teens. And that first era, they weren't thinking about risk adjustment. It was not like, RAF was something we talked about, but it wasn't huge. And look at that era. This is honestly before the real expansion of the Medicare Stars program. Those entities were all heavily focused on like, we got to get people better. We got to control their chronic disease and we keep them out of hospitals. Right. And like, that reflects the infrastructure that they built. I think that thesis, that ethos actually carried through into the group of groups that you see and emerge in the 20 teens, right? The Ioras, the One Medicals, the Oak Streets, the Chens rising. Obviously, they've been there a little earlier. But then post passage of the Affordable Care Act, we see a lot of people, obviously the Alidades, the Agilon, stuff like that, respond to natural incentives, right? And so now we see a ton of money flowing into stars, obviously a good amount of money flowing into risk adjustment from an actuarial perspective. And the fact remains is that it is every business as they're thinking about going through the scaling wormhole has to decide like where are we going to focus first. And the work required to reduce total cost of care by 10% is much different, requires many more different actors, and is much more complicated than the work of raising your stars score by 10%, right?
Sure.
Or
Sure.
getting accurate risk adjustment up by zero point 0.1 from a RAF standpoint. And so we see this great expansion of value-based care and differential payment models inside of Medicare and Medicare Advantage that leads us to get to millions of people inside of accountable care relationships and theoretically into better primary care. That's obviously a win. But now we're realizing, hey, we didn't go far enough, right? And so I think
Mm.
this moment from a value-based care perspective really is that moment of saying, we digging deep and being like, hey, everyone talked about the same statistics of reducing admissions by, double digit percentages or reducing ER visits by double digit percentages. And yet still, when so many of these models have gone after very complex, often structurally marginalized poor folks, right? That there is more to be done in terms of getting them stable. And what is that next generation of work going to look like? I do think I'm a little bit of a Luddite, but when I think about omni-channel, I think of it from like a digital analog and shoe leather kind of perspective. And I'm a shoe leather kind of guy of just hitting the streets. But I do think this is where AI is going to be really interesting in terms of saying, can AI reduce unwanted clinical heterogeneity, right? And that's the trick, right? Like so much of what I've seen in this country just practicing in places like Memphis or Vegas or San Jose or here in Chicago or out east in Connecticut and in New York and in Virginia, like it comes down to just like, we don't always do the things that we know we're supposed to do for people, right? Are we consistent on getting everybody on the right heart failure medications and making sure they get to the right level? If I put you on an antidepressant, Blake, I'm supposed to bring you back in 3 to 4 weeks, check your PHQ-9 score, see if it's improved, and then adjust your medication. But most people never make it back for that adjustment. And then they wonder why their
Mm.
antidepressants aren't working, right? And that leads
Yeah.
to other
Yep.
economic and health consequences. So that's the kind of undesirable heterogeneity that I think from a value-based care perspective. If this moment right now, when there's been so much regulatory and political pressure on MA and value-based care the last couple of years, produces the response of saying, hey, let's go get after it in terms of pushing on the next frontier of clinical excellence, then that starts to get really interesting.
Yeah, I see. So, there's kind of this natural friction there to where you have this transformative technology in AI, which everybody's talking about. And then the kind of more generalized question around, hey, have any value-based care models or, has anything kind of worked to date to bend the cost curve or create kind of better models? And maybe not, from a financing perspective, but I think we have seen a lot of innovation and a lot of change over that time. It's just maybe we haven't found the right
Yeah, and
model to make it work or
it's a debate, right? Like, because David Cutler just came out with his paper like last week, and it's super confusing from the National Bureau of Economic Review. Like, from whatever reason, when economists are looking at healthcare expenditures from 2010 to now, they're saying, hey, expenditures dropped 13% from where we thought they would be. We did bend the cost curve, but then you and I know it doesn't certainly feel like we bent the cost curve at all. And all that we're seeing in total cost of care expenditures does not suggest that we bent the cost curve. So I'm not an
yeah,
economist,
it's so interesting.
but there is this piece of something has happened that has caused some aspect of network effects. And yet we still haven't hit the nail on the head. Right. So
and I want to say,
yeah,
sorry, go ahead.
No. I just we can do more. And John Slotkin talks about this in Hospitalogy today, right? Not to date this podcast, but AI is not built for fee for service. CMS has come out and said the same thing. CMI and Klomp and Abe and these guys have all said the same thing of we are not trying to introduce a billing code for AI, right? In time measured increments. So that's where there is this unique opportunity for folks who have engaged on the value-based care front and are willing to go forward, whether it's, groups like an Oak Street or a ChenMed or an Agilon or hospital systems showing up as a partner that's hey, we know we got to get a handle on people who are sick. Let's figure it out, right? And it's not just through care management programs or just through, hospital at home, but it's through what's the ecosystem and how do we build that in the right allotments of digital analog shoe leather? That's where things are starting to get interesting. It's but I think that the natural skepticism that I think you and others correctly bring to this work is hey, we've seen a lot of market exits, a lot of financing events that have been on the strength of the revenue side. And so it's natural for there to be skepticism on, can we get liquidity events that are based on the total cost of care side to both occur and occur at scale.
Yeah, and I'd like to say for the record, skeptical of the models that are, maybe chasing the risk adjustment or whatever it is. And I know everybody has risk adjustment to a certain extent, like the financing side of it. But I am completely aligned as far as the vision and the theme of and spirit of value-based care. I just think that it can be very loosely defined, and a lot of people see it as a pure financing mechanism. I think that a lot of the conversations I've had recently, and maybe you guys over at CVS have been talking about this too, is this almost imperceptible shift from value-based care to call it high value care in a sense, where there's as like you mentioned and alluded to, the ecosystem is working toward innovation and integrating AI and those sorts of things. You care more about ultimately, who are you serving, right? Like the physicians and the clinicians, and then also the patient. And, maybe we are seeing a slow introduction of, consumerism and consumer forward things into healthcare over time, especially as people engage with AI chatbots more, right? I think that maybe we'll see a natural progression and more automation and ultimately bending the cost curve. But I'm curious for kind of your perspective around those thoughts.
Yeah, it's super interesting because you think about high value care as the frame, right? So if you go back, if we rewind 13, 14 years, 2012, 2013, a lot of the conversation around value-based care was actually in and around, especially on the clinical side and my doctor world, around high value cost conscious care, which is to say, hey, can we build movements around saying, radiology, tell us what tests you shouldn't do, right? Geriatricians, they told us that hey, we shouldn't put feeding tubes in for folks who have advanced dementia because it's terrible for them, it's painful, and it doesn't extend their life, right? Radiology told us, hey, don't order an x-ray for low back pain unless you have these specific indicators, right? We don't need things that we do for no reason. There was this really profound movement around how are we being great stewards of the healthcare system? And I feel Blake, that did not that the ethos of sort of being what's right for patients, what's right for people, translating and hard coding into what are the business practices and clinical workflows and so on and so forth, whether in the fee-for-service systems or in value-based care systems, we didn't get that translation, right? And so I think because again, to your good point, number one, it was easy to sort of go out and say, hey, we're in a value-based care relationship when all you were in was actually just like a shared savings model or some aspect of getting bonused for quality gap closing.
Sure.
Right?
Sure.
So we
Yeah.
labeled value-based care in a bunch of different ways. Everyone like applauded themselves, but we weren't necessarily saying, hey, we need to enable great clinical outcomes. And the way that we do that is by concentrating enough downside risk at a provider level that encourages that provider to shift their clinical operations to actually do the things to manage that risk, right? Like if you have enough downside risk or you're responsible for a population in some way, you're probably going to take part of your operations and make it look a lot more like a ChenMed or an Oak Street or an Iora and do fewer visits that are longer, right? In primary care.
Yeah.
If you're motivated to do that, like the VA, you're probably going to figure out a way to get musculoskeletal and orthopedic consults like to happen within 5 to 7 days or to happen electronically within 24 hours, as opposed to waiting 3 months or 6 months at some places to get in to see an orthopod, right? Like we didn't pull that off. And so we both missed the moment of like societal motion around like, hey, this is the right moral thing to do to like provide high value cost conscious care. And then we didn't get the right economic incentives in place to get the like hardcore operations of value-based care in place and spreading broadly. So we just ended up in this middle morass, right? Of like, everyone can go out there and put out reports of like, oh, 80% of our lives are in value-based arrangements. But are they really, right? And like on the health system side, people can be like, we're doing tons of value-based care. But it's all on an adjacency. And we end up in those systems with folks who are still seeing 28 people a day in primary care. And then they're just coming home to like 40 HCC queries and a bunch of quality gap measures that they're having to take on in their pajama time. And I don't know how much, agentic scribes are going to help take care of all that work of actually, taking care of people. Right. So I think this is where like the rubber is going to hit the road at this moment of like, do we actually transform or do we not? And I think from an Aetna perspective, we're spending a lot of time being like, we know the transformation needs to happen. How are we being very tactical and walking with people to do it? As opposed to what I would say, from being on the other side of the table for so long, Blake, happened in the decade prior from everyone, which was like, hey, here's the risk. It's your problem.
Yeah.
Right? Like dust our hands of it and like, you let us know how you do.
Yeah. Yeah. Like, here you go, hands off. And that got a lot of people into a lot of trouble in the 2020 timeframe. So you just mentioned a really interesting point I'd love to double click on, which is, your role at Aetna and really like business transformation. And I'm stating the obvious here, but there's a lot of people and there's been a lot of national chatter and conversation around, the role of health insurance and NPS scores, right? And all these things. And I know all of you guys are probably aware of that. I'm curious, as you talk about, as you talk about transformation, you're part of this huge warship, you're vertically integrated, you got a PBM and services and the Oak Streets and everything in between, including the insurance plan, which is awesome. Like you guys have a really cool opportunity to create this integrated care model, right? Like if you're able to get there, but it is a huge warship. So how do you think about like, what to prioritize, like within Aetna specifically? What, frameworks are you thinking about? Are there any like shorter term tactical things you're doing, I don't know, in AI or I don't know. How do you kind of, I feel like I've asked you like 20 questions just now, but how do you kind of think about all of that?
So there's much smarter people at Aetna and CVS than me on the AI side who could like fill 3 podcasts with. So I'm going to actually stick to a little bit of analog if that's okay. But I think
great.
where this comes out is to say, okay, stepping back, let's start with the thesis of, from an Aetna perspective, we want to get folks at a time where, people are waiting 3 to 4 months to get into primary care. The assumptions that our systems have operated on for so long, right? Like, okay, our job as a payer is to do transitional care work after somebody leaves the hospital so that they get their appointment scheduled with their PCP and then the PCP is going to pick up the baton. That may or may not be true anymore, right? In a lot of communities around this country, whether you're in rural South Texas, whether you're in, inner city New York City or anywhere in between. Like that's not actually something we can rely on anymore. And so our first question becomes, just to resurrect an old term, what is the medical home that we're putting somebody in? And is that a primary care medical home? Sure. But actually, could it be really a care model, right? Because it's condition based. Like somebody's got a disease that's complex enough, like a chronic kidney disease or congestive heart failure or, active cancer that merits putting them in and around like a place of first contact that's going to be that longitudinal care coordination, care management, and beacon for them, right? Is it that that's more cohort based? Like, so for folks who are dealing with issues at the end of life, for folks who are dealing with all sorts of things, but like foundationally have severe mental illness? Or is it categorical, right? In and around everybody has an experience where they need to get DME at some point, and that tends to be a bad experience. So, like, can we make that better? And how do we use all the levers that we have to make that better? By maybe it's by gold carding certain DME providers so that orders happen faster, right? Or maybe it's by partnering with, other partners who are out there who are going to get delivery guaranteed within 24 hours, right? Or it's using our network sculpting and using our product design to make those copays lower for people, right? How are we using our formularies and other things to make affordability a center part of how we make decisions, right? Like we have a lot of different levers to use as a health plan, and we're not the provider, but how are we actually working to make the system less friction filled? And I'm sure, Blake, you hear that a lot, but I'm trying to make this super tangible, right? Like prime example, Signify goes out and sees hundreds of thousands, if not millions of members across health plans around the country and sees them in the home. And like that hour in a home is an incredibly vulnerable and important moment for building trust. What we started to do with Signify over the last year is to say, hey, when Signify's in the home, they get the clinician gets an alert that says, hey, this person is eligible for this program. That could be an internal Aetna care management program. That could be that they're eligible for, working with one of our specialty value-based care players. It could be that they're attributed to one of our primary care value-based care players, but critically, they've never seen them, right? They haven't engaged, they haven't enrolled. And our Signify clinicians take the patient's phone, dial that number with their consent, and go forward, right? And then we get more engagement in terms of people actually
Wow.
getting into those models, right? Like if you
That's
look at the
great.
pro formas of all these businesses from Landmark all the way through, all these businesses are predicated on at best state getting to 30 to 40% engagement of the population that they're attributed, right? That's an F. What could we be doing in even an analog form, much less in a digital form, to get people just to a D? Right? Like what would it take to actually get something to 60% engagement, which we only see with platforms like CareBridge or others who are doing really interesting things from the technology front, right? So I know I'm belaboring this a bit, but it's like you can use vertical integration, all sorts of things, and there's all sorts of financial ways to do this and other policy things. But we're trying to just be very tactical in and around what at the last mile can we be doing to actually connect the dots and get people the services that we have a hypothesis that they deserve and need, or that they are telling us that they need. And that's it, right? Like, I mean, there's all sorts of things that can come out of that, but I like that because it's like, it's so granular and it's just a piece of like, when I do that, that means that like, if it signifies handing off that patient a Monogram, that means that Monogram then gets to do all their good work and can stop calling this person every 3 days, right? Everybody wins.
Yep. Yeah. And what's interesting about um, maybe distinguishing CVS a little bit, at least in kind of the on the narrative front from like a business perspective is, in my opinion, I feel like a lot of vertical integration from, post ACA to very recently was um, M&A and arbitrage, essentially around kind of financial results and being able to subcapitate and push things and profit pools and those sorts of things. Mostly looking at some of your peers, potentially you guys, not pointing any fingers and not bringing this up to, complain or anything. But to your point around, the flywheel that you guys have with all the various assets you've accumulated or partnered with, whether it's Monogram, like you mentioned, or Signify or Oak Street Health, is you guys have talked about how that really contributes quite a bit to like overall enterprise value, and that is ultimately aligned with conceived like better patient experience and member experience overall, which is what we want to see in healthcare, right? If somebody is engaging with Signify and then they're an Aetna member, and then also I don't know, they're part of Oak Street Health and those sorts of things. That's all integrated, kind of walled garden approach. You're able to kind of control medical costs while getting that patient to the right settings of care. Would you say that that's like kind of ultimately the goal with CVS, or is there any kind of
I
color
think
you would
so.
add to that?
No, I think it's a piece of like in the first couple of innings of VBC, right? The last decade and a half. I think you're right from a broad industry context that like we've seen a bunch of acquisitions. I think there's been variability on whether how much we've seen about the connectivity into those places and getting on both sides of any of those relationships, the real depth of relationships to make sure that the follow through happens of connecting the dots, right? We know, you know this from you yourself, your parents, your family. I know this from my own family and like my patients. People are desperate for us to help them connect the dots, right? And so we've heard so many things every time. Like, is it blockchain that will help us connect the dots? Is it social media that will help us connect the dots? Is it a new app that will help us connect the dots? Now is it AI that's going to help us connect the dots? But in reality, all those things can be wonderful adjuncts and enablers, but it requires the conviction of really, really understanding, hey, at this basic level, here is what has to happen for that last mile thing to occur, right? If I want someone to get a vaccine for the flu, what do I have to do to make sure that happens in a no copay manner at a Minute Clinic for an Aetna member who is a ChenMed member, right? Like that kind of connectivity is like actually quite complex, not because of it, that it's technically complex, but because it requires dealing with human behavior and adjusting to it. And so I think we spend a lot of time, particularly from a behavioral economics perspective at CVS, with some of the smartest behavioral economists I've ever seen, actually, really thinking through what are all the different ways we are nudging people through this. And I think what's been really fun for me to see is that how that then spreads through Aetna, through CareMore, through Oak Street, through retail and so on and so forth to drive this sort of consumer behavior. We've talked about consumerism a lot in healthcare the last 20 years, but like it honestly, I feel like it often falls flat because like we don't know how to empower people in asymmetric information environments
Yeah.
as a global
Yeah.
society, as a society, American society. And so here we're saying, okay, we have to walk with people, whether that again, digitally, analog, or shoe leather. And that's what we're
Yeah.
focused on.
Yeah. I'm curious. You mentioned behavioral economists. What's some kind of interesting factoids you picked up, like in working with them and talking to them?
It's so fascinating. Like, you know, for example, like some things work, some things don't. But like when we on the retail side on CVS, using our, the vast number of people who interact with a CVS every day or fill their prescriptions at CVS every day, when we or from an Aetna perspective, right? When we think about our membership, you know, you would be stunned at what the value is of text-based reminders for people to not just go get a flu shot or remember to like visit their CVS if RSV rates are spiking, but to be like, hey, you're somebody who should probably have a conversation with your doctor about, whether you would benefit from cardiac rehab. Go talk to your doctor about this and bring them this message, right? Um, well, in a prior generation, we used to do this through letters. We never knew whether the letters were doing it or people were just happen. It was just happenstance that people were following those recommendations. Now we've gotten a lot more sophisticated about being able to do a lot of A/B testing, see what works and what doesn't work, turn campaigns on in days and if not weeks, right? In terms of being able to iterate on these things, and we can actually nudge people towards behaviors that we think are useful, right? But so if I'm nudging someone towards cardiac rehab, which is one of the most effective things across the country, your friend and mine, Michael Poku, will go on a full diatribe as a doctor about how valuable cardiac rehab is and what it does from like ultimate cardiac outcomes, and we're preventing recurrence of heart failure, exacerbations, or heart attacks or stuff like that. But then, so if I'm nudging someone into that from the behavioral economics side, then I, as the health plan, have to connect it and say, hey, I should think about how to make cardiac rehab more affordable because it's 36 sessions that you have to go to over a series of weeks. And if each one of those has a big copay, people drop out, right? So like, I think that it's both in the piece of like, hey, there's really cool nudge work that we can see. And, we've seen this in the literature before from Mitesh Patel and Penn and others, right? That who've done this. But then how am I connecting that in to say my product structure supports what's happening over here, right? And then I'm also able to offer both digital and in-person options in my network that can have people sign up for cardiac rehab quickly and start that work within 7 to 10 days, right? Like that's the connecting the ecosystem that we don't talk about because it's not sexy, but it's incredibly important, which is very different than when we talk about connecting the ecosystem and my Whoop pairing with my CVS app, which then enables a drone to fly to my house, right? That's a different thing.
Yeah. Yeah. First of all, random shout out to Michael Poku. Michael, if you're listening to this, got to have you on. We got to reconnect. Great guy.
Absolutely.
Second of all, curious, just like how do we enable that? Like, is it technology? Like, what's like benefit design? What are the components that creates a more kind of connected ecosystem from that standpoint?
I think it is a piece of like, it gets back to, I think you talked about this a lot in other places, like how are you actually pushing on cross-functional design and implementation? And are you committed to actual iteration, right? I think too often in healthcare, we think with either a fee-for-service mindset or a commercial mindset of like, if we can't deploy this quickly and see return in 6 months, then it's not worth doing. And healthcare is slow, right? Like getting people's behaviors changed is slow. Like that is so you have to think fast and slow in that way, the Kahneman reference, right? Like you have to drive to a place where we're saying, okay, we are going to run rigorous work here. And I think many plans have done this. I think we at CVS think we're special at this because of all the different players in our ecosystem that we have to work with. We are expecting this will take 2 to 3 years to get return. We are going to structure the cross-functional teams to be working throughout in that way using the tools of product development or agile development to drive 2 to 4 week sprints on things, pull up, iterate, do retro meetings, like have the real work of that infrastructure there, and then be able to connect the dots of like, okay, if I'm suggesting that you go to your PCP after a hospitalization, then maybe that nudge that you're getting should, and this is a debate we're having right now, should also prompt you to like click here to schedule with your PCP, right? And if you don't have one, click this link to schedule with MinuteClinic, right? Like who will take that time for you or for somebody else, right? Like, or to schedule with, Doctronic. Like, I don't know. I'm just picking them at random. But my point is that like, we have to constantly be driving people towards next best actions and then provide them the connectivity to make sure that if we're sending them somewhere, that then that follow through is really good, right? And it's consistent, and then we track for that follow through, right? If I have a partner who's committing to a 15-second SLA when Signify is dialing a member's phone for them, and they're not picking up until 85 seconds later, that's something I actually have to track and govern, right? It requires for us as a health plan to actually lean far more into clinical operations than we necessarily know how to we normally do, because our world is normally about authorizations and approvals and product design and other pieces. So it takes an enterprise like this that's doing so many different things to have the muscle memory across all these different kind of components or different kinds of actions to make that work. Does that make sense?
That does make sense. And I feel like it's just easier said than done, Like,
yeah, 100%.
And from my opinion, or like from my experience, I've been in healthcare like a decade this year, and I feel like the problems are very easy to, thank you. Masochist over here. I feel like the problems are very easy to identify, but obviously like the devil was in the details as far as like, hey, do we have the data to do this? Like the pipes built, the infrastructure, the people, the AI, like whatever it is, pick your poison. But that's kind of ultimately where things fall apart.
I think like the access model is a great example of this, right? Like I think everyone's like, oh, this access model coming from the innovation center, it's going to be doing great things and it's going to enable all this great work. And I'm hopeful it will, right? But for it to really work, when it's a model that's saying, hey, you got to show us in real time that you're driving good clinical outcomes, and we're going to withhold 50% of your, modest payment to begin with to drive more policy forward, then we have to get like as close to real-time data exchange as possible in a lot of different actors in this country. And you and I both know that FHIR has not, taken hold of the healthcare world as many have hoped it would have up to this point, right? So like from an interoperability standpoint, there are huge dependencies for many different programs that all sound wonderful and I believe in and like want them to work. But like, are we willing to make the infrastructure investments in the places that actually make those things happen? I think that becomes a really critical question. And sometimes folks who are new to healthcare, like Mark Cuban, can do incredibly powerful things. And then sometimes folks who are new to healthcare may not understand some of those details. That's not Mark Cuban. He's dealt in those details in a lot of ways. But like folks who are on this other side who may not realize like all this the strategy in the world will be eaten up if you're still faxing things, right? Like
Yeah, structural problems. Um, and there's been a lot of chatter, especially in 2026, from the investor side, the conferences and side conversations, where like the best uses of AI will be in, or best investments in AI will be in kind of the infrastructure side and the plumbing and the unsexy things that nobody wants to deal with, but like it has to be dealt with, and the companies that do it will, reap the rewards of that, and hopefully we all will, right? Hopeful. I like to think of AI as like magical fairy dust we can just sprinkle on healthcare and it'll solve all of our problems. So I'm hopeful that's the reality we'll see in like 5 years.
I share your optimism. I want to get there too. And I think that's where I want to be really thoughtful about like how are we setting up, you know, payment structures in the right way to make that work? How are we incentivizing the connectivity work that's more than just look like what we're seeing right now, right? A lot of folks are focused on revenue cycle, and there's a whole bunch of AI supporting health systems on that side. And then everybody's saying that, then the next wave will be AI focused on authorizations, right? And if that's where we get innovation 5 years from now and that's it, we will not have succeeded in actually making a less miserable system, right? But we are at this moment right now where you could imagine there's some really cool stuff out there, Blake, on what I would call like agentic CHWs, right? Where you can take the ethos of the best care managers on a health plan or in a hospital or in a primary care group and scale that, you know, 15x, 20x, because you're able to give that kind of support to everyone in a plan or everyone in a panel, not just to the 10% most complicated, right? And like that kind of combination of navigation, accompaniment, and like task action planning and follow through, that's been core to so many of these models. CareMore, CityBlock, Iora, you name like Impact for Healthcare, you name it. Like over and over again, we see these, the Camden Coalition. But like we move that from being for only the most complex to being for everyone. You start to bring a lot less misery into the health out. Pulling misery out of the healthcare system because people feel like they have something to rely on. That becomes incredibly powerful. That has to be incentivized in the right structures, and that's not going to be through fee for service payment, right? So that's where we are really looking to lean in with players out there like the Cleveland Clinics who are saying, hey, we're a big legacy health system. We do a lot of really important work. We're medical innovators, and we want to innovate on the payment side. And so help us think through how we change our operations to make that work and how you help us get there, not that you sit there in an antagonistic position, right? So that's, I think, the fun part of
Yeah.
the job
Yeah.
right now. Because those places like the HCAs of the world, the Cleveland Clinics of the world, the Northwesterns of the world, they're doing some really cool stuff on the clinical side as well. In like making sure that all those medications that we were talking about for heart failure, for depression, start to get titrated automatically with a human in the loop, right? That they don't need another visit. They don't like, and so we're actually getting better clinical care. How are we enabling that for them also? So they're not feeling like wondering that when are we going to pull the rug out from under them in some way, shape, or
Yeah.
form, right? So
Yeah.
if this moment works, it will actually pull out misery, but it also pulls out mistrust. And that's going to be really interesting.
No, I love that response, because I feel like that's like at the core, almost like a societal core today is trust, right?
Yeah.
Especially between payers and providers. I mean, there's a natural friction there and a mistrust. And so, a lot of I've heard a lot from the health system side around like, hey, MA, they reimburse us 85 cents in the dollar and they deny us. And it's just like so administratively burdensome and all these things.
Yeah.
And then you guys, the role of the payer is to be the check on the system and to aggregate lives and risk and find best care models and those sorts of things. And that's like kind of the spirit, the best spirit of the health insurance side. So I'm curious, how do you solve for trust, like how do you get health systems to trust you guys and be like, let's work together when there is so much, past vitriol in the system. And, we're in an interesting environment where both sides are kind of getting hit right now, right? The Medicare Advantage and a lot of the carriers have been hit by V28 and the
Right.
advance rate notice. And then on the health system side, there's, labor inflation and ACA subsidy expiration and those sorts of things. So when both sides are getting hit and then there's mistrust between the two sides, like what's like the end game here in your opinion?
Somebody's got to start by bringing the 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 peace symbol along, right? And and asking people to stack down. And so on some level, we feel that we are doing that. Obviously, we made a bunch of commitments through AHIP, but we're going beyond that to say, hey, logically, we know that let's start building the right kind of authorization bundles so that when somebody's being actively treated for cancer, they're getting those authorizations for all the imaging that they're going to need over that 3-month period, but they're also getting the authorization for their anti-nausea medication, right? So it's actually all set up and we just remove the things that we have learned the hard way cause annoyance, frustration, anger in a lot of people, right? Now we prove that those work, and when we inevitably stumble, that we are responsive about how we pick back up, right? That's how we start to get people to trust us. A lot of the stuff that we've been doing on prior auth simplification, especially with folks who we realize, as United and others have, right, that they're very good actors, right, and not folks who are driving any fraud, waste, or abuse. And we are able to partner with health systems, like one health system in the Midwest, where we're saving in terms literally dozens of days in a given 6-month period that their teams were otherwise spending on appeals and peer-to-peers and stuff like that, right?
Mm-hmm.
Look, scar tissue builds up in American medicine for people in a lot of different ways. And sometimes it's fine dissection, like in a surgical setting with a bovie. And sometimes it's very blunt, where you're just getting in there and you're trying to break it up. And this is a mix of both, but it's about recognizing that removing that scar tissue takes time and it takes consistency, right? And so I think that's part of it, Blake, of demonstrating that hey, we're not here to pull the rug out from under you as we go forward, recognizing that both sides have trepidation, leaning into that and enabling honest conversation, right? We're spending a lot of time right now through our Aetna clinical collaborative program, uh, where we are going back to the future and bringing nurses from Aetna, care management nurses, back to the bedside in certain hospitals where they are trying to be the easy button for hospital care managers, right? Helping to do collaborative discharge planning with our members at the bedside, coming back saying, hey, this person's going to need home health. You put in these referrals. I'll make sure we get those authorizations approved, right? We'll get this moving together. It looks like they might need a shower chair. If you can order that, I'll make sure this thing's happen on our side, right? That's the actual kind of coordination that existed 15 years ago, for 20 years ago in that first era of managed care. Because you know why? Back then we paid most hospital contracts, Blake, were per diem, right? So when hospitals were being paid per day, there's a lot of incentive for plans and hospitals to work together to make sure, length of stay was optimized. In a DRG world, hospitals are still tracking length of stay, but it's not as critical as it once was from a payment perspective. And so plans and hospitals are not necessarily partnering on that as much as they used to. Hospitals care about it because of throughput, right? And so that's a different set of incentives and different motives. But now us coming back and being like, hey, we recognize you're trying to get people out faster. We want to make sure they get out safer. And so we can work together. And maybe when we work together, we can start auto-authorizing, SNF transitions quickly. So, right. So you're not waiting 3 days to hear back to see if that rehab appeal is needed, right? Those are the kinds of things that save valuable time and have real financial return. And so this is the kind of stuff where we're going back to the future, man. And I think that is the kind of ground game that is going to help us rebuild trust across this trust deprived system.
Yeah. Yeah, absolutely. And so I'm curious, you mentioned kind of, care managers, which is a very cool, back to the future concepts. Where are other parts of, hospital or payer provider collaboration that's kind of low hanging fruit to, start with? right? Like I think about things like, readmissions penalties or other, kind of like quality initiatives. Like where have you guys kind of identified areas that you guys can start to rebuild that trust?
Yeah, it's a good question. I think it depends on the hospital system, honestly, Blake. Like what, because like what are they thinking about? Where are they going? So, for example, with hospital systems who are worried about their ER throughput and like boarding and stuff like that, we can spend time with them being like, hey, are there things that you need from us, like as you're exploring your hospital at home portfolio, right? Can we be doing more to simplify those authorization process, help people get out faster? Again, at hospitals where we have embedded nurses, is that something that we can do? Is there synergy there? Like many hospitals are building out their own programs in this space, right? To help free up their ERs. Why wouldn't we help them do that? Right? That's a win for everyone, but particularly the patient, right? Yeah, effective care in the right setting that's cost effective, that keeps them at home and gets them healthier. Like we should be helping to drive that. But there may be other hospital systems for whom they're thinking about, hey, how can I, you know, take my oncology strategy in a complicated market to the next level? What's a differentiator there? Or I I realize that my orthopedic practices have to start really prioritizing Medicare patients because commercial alone is not going to do this. But how do I overcome some of the historical biases towards taking government insured lives into the orthopedics practice or into a plastics practice or stuff like that? And so that's where we can say, hey, how do we help think through functional partnerships with you all that identify people, ways for our members to get faster access into your best surgeons. And in exchange, we're able to surround them with wraparound care management models, whether the ones that we build or ones that come from, you know, partners like a Vori or a Right Move or a Taylor Care or something like that, right? And then like we're making sure there's end-to-end work all the way from the original digital PT front door through when people need surgery and then after surgery. That care coordination's happening, that care management's happening. People are getting discharged safely and not bouncing back. And like we can hopefully make that process easier. Again, going back to the levers that we control in terms of, co-payment structure or product design or, how we think through like gold carding and authorizations in that way to make these kinds of processes seamless so that we're nudging people through to who we think are the kinds of surgeons and the kinds of institutions that you and I would want our mothers to go for back surgery, right? That's the kind of stuff where depending on what a hospital system or a health system or a value-based care provider group or an independent practice wants to find relief on, we think that we have a bunch of potential options to help drive that. I think what we've learned, all of us, I think in the industry have learned the hard way is we shouldn't do all of them at once everywhere. We should be targeted and be able to drive really strong clinical operations to make sure these work.
Yeah. Yeah. That's super interesting. Makes a lot of sense. What's interesting to me in having conversations on the health system or provider side is how the conversation, since basically like, I don't know, since you pretty much joined Aetna, has been driven around like fee for service and risk off in the sense of we want more fee for service and more utilization because of the general, trends that are playing out. Um, in saying like, hey, we can get our occupancy up and the right patients into our hospitals and those sorts of things. So uh, I think my broader statement here is there's natural friction between payers and providers. There are ways to work together, but you kind of have to, find the right partners and the people who want to think bigger than their kind of ongoing reality, right? Because we might be in peak hospital operating land now, but a year from now, we might look completely different. Volume seems to be softening and things are shifting, right? Secularly, subsidies are expiring, all the things that I talked about before. Um, so all of these things also affect payers, at least right now. I'm curious, like, just like around the point I'm trying to get to is there are a lot of structural challenges to the insurance business right now, whether it's the political rhetoric around, overpayments to Medicare, Medicare Advantage, the high utilization environments, GLP-1s and specialty drugs and like long-term incentives of covering those versus not. consumerism and all of these things. Um, my question for you, after rambling through all of that, is how do you kind of like triage these different issues like in your day to day, and like where you see Aetna needing help in various arenas? You guys have downsized to a certain level in MA and those sorts of things. But how would you kind of like assess the current state of your role and your ability to invoke change at Aetna, given so many things you guys have to deal with?
Yeah, man, it's such a good question. I appreciated the road that you took to get there. I think, look, everybody's at their own place in that journey of change, right? And like we have to respect where people are. And like, I learned that in medical school, right? Like some people are pre-contemplative, some people are ready to quit smoking, some people have never even thought about this, and you just got to meet people where they are and you go forward. I think the same is true when we think about payer-provider relations. And not every look, I mean, this has been a zenith time for health systems, right? The last couple of years in and around everything that we've seen. I think that there are a number of actors out there, and we talk to them every day, who are interested in, again, pulling out that misery, pulling out that mistrust, and like walking the right way, right? Like when we think about the kinds of pathways that are going to actually activate this, I think we just have to be very defined. So it comes back to that care model approach of like, at a condition level, you can do things that people understand beyond bundles to say, hey, what are the financial components here? In full risk may not make sense in a bunch of places, but subcapitation could, right, for professional institutional risk. And so what does that mean then in terms of getting as many people into those kinds of relationships for you with the health system so that you're shifting some of your operations to operate in a manner that's more coordinated, more proactive, less volume driven, but is thinking about the right thing of how to make sure the right clinical outcomes are happening, right? Those are things that we are spending time on. I think when we think about it from a cohort perspective, right? Who are the right partners, whether it's internal to CVS or whether it's folks who are coming out of the venture community or the PE community that are building those chassis of intensive care management and care coordination and clinical work to make sure people don't fall through the cracks of health systems or other places. And these are populations like folks with SMI or folks at the end of life that often frustrate our health system partners because they're frequent flyers, they're utilizers, they're maybe not the payer mix they want, whatever, but that they want help with too and they don't know where to go, right? So much of healthcare's problems are actors, whether when I was a doc in an ER or as a hospitalist, or even today in the primary care setting, not knowing what to do and throwing my hands up and defaulting to the easiest thing, which is just go to an ER, right?
Hmm.
So we are saying, how do we help you feel empowered and feel like you have a knowledge of the resources that are available to not have to default to that position? Because if we can fix that, then inevitably a lot of the actors in this space win, right? That
Yeah.
sounds very Pollyannish. I assure you, Blake, it is incredibly tactical to figure out how to make that work. And it requires a bunch of different things, including, you know, recognizing that sometimes that person from the venture community who's building that company with a great severe mental illness chassis, right, like a firsthand or somebody, is going to garner more trust from the health system than necessarily I do as a payer today. And so it's okay to come together and recognize that by building trust between that chassis organization and the health system, that's also bringing me up, right? And sometimes that might be doing it through one of our own assets, like a Signify or an Oak Street or a Minute Clinic, right? So on and so forth. But it's all in the same piece of saying, hey, if I want to encourage oncologists to think about weight-based dosing for certain oncologic drugs as opposed to standard dosing, because it's equally effective, but the cost differential is significant, who is the right person to have that conversation? Is it a trusted oncology partner like an Evolent or a Time? Is it the specialty pharmacy CVS? Is it CareMore? Is it Aetna? And for different groups, it's going to be different ones of those, right? And so like we can all talk about site of service and white bagging and all these things all day long, but ultimately it's at the end point of actually where that decision is made that we have to convince, right? And we have to figure out who's the maximally trusted person there and then go down that path. So again, I'm not trying to sound like a rube, but this is just the work. And it requires seeing the whole field, understanding how people react to things, being a strong student of human behavior, and then just, messing it up a bunch of times before you get it right.
Yeah. Yeah. No, I appreciate that answer. That's I think that all of your answers have been super thoughtful. And in one quick caveat, I'd like to say, I think some folks who work at hospitals might, cringe at me saying it's like peak hospital operating environment when half the hospitals are underwater or whatever. So I
Right, right, right,
apologize
right.
to that cohort. I was talking more about the large regionals who are getting ahead and those sorts of things. So would
It's
like to caveat
the
that.
ones that get the beautiful hospitality graphs. It's the tenant. It's
Exactly.
yeah.
Yes. Hey, I'm only one person. I can only cover so many IDNs, but and maybe AI can expand that pool, or maybe everyone can just send me their financial and operating data. That'd be
Yeah,
great
if they
too.
just send you if they send you all their financial statements, it's fine, right?
Yeah, I'm sure. I'm sure that's a technology
You send
play.
them some
I'm
golf
sure I
balls,
could.
you send them the golf balls back, everything wins.
Yeah, I do have some Hospitalogy branded Pro V1s, so like that could be a pretty good deal. I think so. Okay, Ali, I've got just one more question, more on like a one more healthcare question on like just
Yeah.
like your career trajectory that I'm curious about, because you've worked at two organizations, both advanced primary care, advanced risk, that were ultimately absorbed into other organizations, which is I feel like pretty unique. So I'm curious, and one of those organizations you're still with, from a parent company perspective. So I'm curious, like, what was your experience in employee 34 at Iora Health? And that was acquired by One Medical, then acquired by Amazon, right?
Yep.
And then also, Oak Street Health acquired by CVS, and now you're at Aetna. So, what was it like, being acquired, or shifts in models or thinking or culture? Because I feel like that's a pretty unique lens to have in your career.
Yeah, and I'll say the other one that you probably don't know about is that I came to CareMore in the wake of the Anthem acquisition of CareMore. I think at a time where Anthem was trying to figure out, hey, what do I do with this thing? Right? So what I'll say is each of these three gives a different perspective, but what I think it comes down to, and honestly, a big reason why I jumped at it, and I'm so glad that I did, is that the synergies that are proposed at the time of the purchase are usually not necessarily that far of a leap, right? From an operations perspective, but it requires two things, which we talked about here. One, the right time horizon to recognize how long it's going to take for some of these things to work out, right? Like if you believe that Amazon employees are going into should be going into one medical practices, well, it takes time for that process to happen, right? If you believe that Anthem should use CareMore as their Medicare Advantage chassis in lots of different places, or as their managed Medicaid chassis in a bunch of different places, right? Well, it takes time for those deals to flow through and then for that work to percolate to show the results over 18 to 24 months, right? So on and so forth. And so that requires one, the right time horizon, and then two, the trust necessary for that to flow, right? Like where like people are recognizing, hey, there's going to be stumbles along this path, and we have consistent leadership and consistent alignment that we're going to let this percolate. And so I think one of the biggest thrills for me has been able to be on this side and enable the Signify deal to percolate through lots of different kinds of activities, right? Including what we talked about with Signify Direct Connect. To be that person helping to ensure that the Oak Street deal continues to percolate and gets to the place that we want it to, right? And so I find like at CVS, we talk a lot about building enterprise athletes actually for exactly this purpose of making sure that people understand the different dynamics of multiple businesses and can be those go-betweens. They can be those dot connectors, and that they can carry these strategies through. It's honestly the most exciting part of my job. You can tell I get passionate about things, but I do think this is actually a really fun connecting the dots and building simple things that actually drive that value. I think a lot of those acquisitions get hung up because the nature of healthcare hiring and careers is such that that can be quick, or we don't give the right time horizons for these things to percolate and to manifest. And so that's what I'm hoping we're doing the right way at CVS today. And it's been a really encouraging journey so far.
Yeah, thank you. Thank you for that. That's interesting. And communication is the key to success, right? Like having those glue people in the organization that are able to communicate different priorities, and so you're right there too. So super interesting. So just to round out the podcast, I always ask everybody at the end, um, I would love to know, is there, a piece of content or a book or, any sort of media that you've consumed in your life that has really changed your perspective on kind of how you live your life?
Let me see if I have it here. I don't, but I would say my favorite book, the one I recommend to everyone. These two Washington Post reporters wrote this fantastic book all around like the 93, 94 Hillary Care, uh, you know, thesis and failure. And it is a phenomenal read of thinking about how does industry, politics, policy, human behavior, and just like plain old healthcare failures intersect to take great ideas and like drive them towards resounding failures. How does ego play in that? How does money play in that? I think for anyone who wants to think about and understand healthcare, so much of this is reading history and recognizing these are all cycles that have happened before, and like how do we get through those cycles. So if that's the one thing, right? A lot of people talk about Paul Starr and like the the social transformation of American medicine. That's a great book too, but the system is mine. That like I just think opened my eyes to the complexity and the fun of corporate strategy, political strategy, policy, and policy making, and how it all comes together in a really weird and fun way.
Yeah, very cool. Okay. I like to tell the other folks that have been on, like I'm amassing this great Goodreads to read section. So I will add that to the list. I also think like in general, like the cycles of healthcare, like series or something could be pretty interesting or cool because I do feel like a lot of people who are new to healthcare and or have even been in healthcare for 10 years don't necessarily have that historical context. So that's that'd be pretty cool. So anyway, Ali Khan, thank you so much for being on Claims Denied, the Hospitalogy podcast. Um, I really appreciate the time today. It was very, very insightful and loved hearing your perspective at Aetna. Best of luck to you guys the rest of the year. And it's great catching up with you.
Like as always, this is a blast. Looking forward to more.